the sickle cell program and the thrombosis and hemostasis program at the University of Colorado. She's a longtime leader and a pioneer in clinical investigation of sickle cell disease, and she's going to talk about the many colors and many complications of sickle cell disease in terms of progress in clinical investigation. Dr. Hassell. And I think, yeah, slideshow and we're off. Thank you.
Thank you very much, and let me add to the list my gratitude for being invited to present to share this very special day with a long-standing colleague and friend. I looked at the august list of invitees and I thought, how's he going to introduce me? My CV is short, I work in Colorado where there are more sheep than people, and I realized that actually my credentials are I am a native Minnesotan. I am from northern Minnesota, which is like the red stepchild in Minnesota, and so I represent a mark of diversity here amongst the Minnesotans. And I am pleased to serve in that role, and also to offer a humble perspective from a person who swims through the adult world of sickle cell care in talking about what I've called the code of many colors. Jim has taught me always to put up a disclosure slide, so here it is for your perusal. Nothing is pertinent today, because the most important different source of disclosure I would have for you today is that I'm going to be raising more questions, frankly simplistic ones, than providing answers. That the true solution to the questions I raise actually lie with other speakers, with Dr. Walters, who's to follow, who has the cure in hand, to Dr. Hebel, who characterizes and recognizes the multiplicity of factors that are engaged in sickle cell disease. And most importantly, let me acknowledge up front, you'll say, but wait, that's such a small thing and such a small or an unusual complication, because I fully recognize the horse has left the barn for my presentation. The sickle red blood cells have come and done their damage. The sickling and adhesion has occurred. But many of us work in that barn, where we need to take care of the individuals who are suffering from, as Dr. Kutlar called them, the downstream complications of sickling. And my hope today is to broaden conceptually how you think about an individual you may face clinically who has sickle cell disease and its attendant complications. And I must say, the only other piece of pressure I'm feeling is that in the back, you should know that Mrs. Ekman, who is not so much a content expert, is a communications specialist. So no pressure, but now I'm being graded on presentation skills. All right. So in the context that I've outlaid, I'd like to talk with you today about 3 examples of clinical complications and put a different mindset for you perhaps. So the first will be around acute manifestations of sickle cell disease, exemplified by multi-organ failure. The second is what I would call a subacute issue in sickle cell disease, which is pregnancy, and then a chronic manifestation, which in contrast to how we usually think about this disease would be pain, as Dr. Kutlar has addressed. The first context I'd like to paint is when I discuss sickle cell disease with residents, medical students, frankly, anyone who will listen to me in Colorado, it's like draw an analogy between diabetes and sickle cell disease. Blood sugar, when high, goes everywhere and potentially damages anything. The same is true of a sickle red blood cell, whether sickled or unsickled. And so to the extent that an individual suffers an acute or chronic complication is as much about that host and the polymorphic, the polygenetic, and variability and other factors that might be acquired as to what the host does in response to those red cells. So with due respect to Dr. Joyner and other red cell focused colleagues, mine is to talk about the downstream consequences once, as I said, that horse has left the barn. So let's take a case. Everyone step back, those of you who are professionals, nursing, genetics counselors, physicians, back to when you were doing your basic general training. You're in a general clinic. And we hear about, or in this case in the hospital, a 20-year-old African-American man who was found unresponsive in his apartment. He was last seen about 36 hours ago when he left work feeling bad. By the way, it's about mid-January. His initial vital signs you can see are greatly deranged. He's hypotensive, he's tachycardic, he's febrile, he's hypoxic, although Denver's L2 is not so bad. Respiratory rate's 36, his white count is very high, he has clear hepatic and renal dysfunction. Because it's flu season, a rapid flu test is positive, and here's his chest x-ray. So every medical student, every nursing student on the team knows what this is. This is sepsis. And in the modern era, we actually talk about stages that start with what's called a systemic inflammatory response syndrome, or SIRS. We see it a lot on the hematology consult service because in addition to the changes that you see depicted, it sucks down platelets as well without DIC. So it's a temperature, high or too low, tachycardia, a respiratory rate that demonstrates distress, or a white count that's, again, too high or too low, and thrombocytopenia is often seen in my experience. Sepsis is the term we apply when there's a potential pathogen. This young man has sepsis by definition. Severe sepsis is when you have a potential pathogen plus some of these criteria, and hypotension or high blood lactate. And launched into, from a recent New England Journal article review, a discussion about sepsis, how multi-organ failure can occur. It focuses on thrombosis, activation of inflammatory mediators, increased vascular permeability with edema in tissues, and with a subsequent tissue dysfunction and multi-organ failure. And on top of that, there are multiple host mechanisms that include pro-inflammatory and anti-inflammatory. Mine is not today to go into the nuances of these. We'll hear some discussion of this in the context of sickle cell from Dr. Hassell, but to simply note that long discussions take place on the wards about this entirely newly characterized and increasingly well characterized pathophysiologic mechanism in sepsis or in SIRS. The treatment is, of course, to address the underlying cause or stimulus, to provide supportive measures. There's an entire portfolio of research efforts being made: anti-endotoxins, anti-inflammatories, antithrombotics, even statins are being used in the study of SIRS and sepsis, as well as various pressors, including vasopressin. And it's interesting in this recent review article that they suggested that in this setting that hydrocortisone of 200 to 300 milligrams per day during the hypotensive phase is actually potentially beneficial, reinforcing this old internist notion no one should die without steroids in the ICU. And so in this setting, you have an entire ICU room filled with individuals who are by the bedside proposing their intervention, proposing their study, monitoring multiple things. What if I told you this person has sickle cell anemia? Suddenly the room is empty, except for the respiratory therapist who's checking the vent. And their answer is, well, it's sickle cell, call hematology. The good news is, here at least, while they used to, would have called Dr. Ekman. And that is particularly apropos for this case discussion, because back in the day, he actually helped to characterize a phenomenon called the acute multi-organ failure syndrome, potentially catastrophic complication of acute severe pain episodes. And the two other authors are in the audience. And we characterized 17 episodes in 14 patients with fever, tachycardia, respiratory distress, mental status changes, thrombocytopenia. We characterized SIRS, we just didn't know what to call it. There was not a bloodstream infection, although in some cases there was a suspected pathogen. So actually this technically met the criteria for sepsis, and antibiotics were given, although bacterial infection was not proven. And we characterized this syndrome as having acute chest syndrome, hepatic and/or renal failure. Now, the speculation I would give you is this really, in my broader context, sickle red blood cells stimulating SIRS, stimulating a septic-like state in that pathophysiologic mechanism that we recognize now? Now, I blame the red cells because of the observation we made, which is that if transfusion was given, initiated rapidly at the onset of clinical deterioration, that these patients had a remarkable turnaround, along with the supportive care of the day, to baseline normal organ function, in some cases in the course of 24 hours. Now, it took a lot of transfusion, as you can see, 8 or 9 units per individual. And there was an impression, although difficult to prove in a small case series, that perhaps exchanging rather than providing serial simple transfusion made benefit sooner. But in fact, if you could get rid of the toxic red cells and perhaps correct the anemia, that we could in fact reverse this syndrome in sickle cell disease. And this was our characterization at the time, red cell sickle, that there was microvascular occlusion, there was diffuse tissue edema that could lead to fat embolism, which we now know is a pathway for acute chest syndrome and other things. Infection contributed to hypoxia, but it was anchored on sickling and vasoocclusion with tissue ischemia. And it could be interrupted, to be fair, if you got there soon enough with transfusion. But in the modern era, we are far more sophisticated. We know that sickle red blood cells are trouble even when they're not sickling. This has to do with the adhesion, the endothelial activation, white cell and even platelet recruitment. We'll hear a much more elegant presentation of this from Dr. Hassell, and I've heard it alluded to already. As importantly, perhaps giving even a few units of normal red blood cells may be an antidote. It may not be sufficient to correct the anemia, but it may be enough to sump up the free fatty acids that we know might create endocapillary leak in the pulmonary endothelium, for example. Maybe normal red blood cells are better delivery for nitric oxide, although that's recently been called into question. And so my only point is, hematologists think about correcting anemia, but red cells may actually be an antidote. And then, frankly, as importantly, and more to my point this morning, is people are still dying of multi-organ failure and other sickle cell-related complications despite transfusion. Now, it might be that we intervene too late to reverse the SIRS process that's begun, or it might be that once it's started, we cannot rescue with a sufficient number of normal red blood cells to reverse the process. And so this is just Dr. Hebel's one of his many characterizations. There are many things taking place that simply giving red cells may or may not be able to interrupt once the cascade has begun. And so it's time to think outside the box. Firstly, not everyone can get red cells as a rescue. They may be at a place where red cells are not immediately available. There may be a limitation on the other end of the spectrum where there's alloimmunization. It is likely, as you've heard, a theme already emerging today, that it's going to take multimodal therapy, especially as this process advances and self-perpetuates beyond what the sickling and adhesion did in the first place. And we need colleagues who think about things like SIRS, like pathways, or we are destined to wander our field in a box without thinking outside of it in a way that actually can better treat and rescue lives in this very acute, severe complication. But let's step away and back into your training mode. Back in the early days, 33-year-old African-American woman with a history of 2 pregnancies with intrauterine growth retardation. She had fetal demise at 24 and 28 weeks with preeclampsia in the second pregnancy. Depicted here in A and B, you see the normal fetal and maternal side of a normal placenta, and then you can see the damage that was found on both the fetal and maternal side. A common problem for women and women's health, recurrent pregnancy loss. So after 2 losses, an assessment is clear, recommended by guidelines and societies. Look for genetic factors. Look at the peripheral karyotypes of the parents and also the products of consumption. Look for antiphospholipid antibody syndrome. Much of my time in Colorado was actually spent in the world of thrombophilia and in that arena. Look for uterine anatomy problems, hysteroscopy, transvaginal ultrasound. Look at hormonal and metabolic factors, thyroid, prolactin, and of course lifestyle variables. What's recognized, especially with fetal demise and with pregnancy-induced hypertensive disorders, is there may be thrombosis in the placenta, there may be inflammation, and especially in antiphospholipid antibody syndrome and early losses, there's complement binding, a failure of placentation. It's actually not a thrombotic disorder in the early losses, but other sorts of pathways, including chemokines, play a role. Later on, there is a vasculopathy that's seen and a loss of the physiologic regulation of spiral arteries. All of this is thought about ubiquitously and universally in the woman who presents, especially with recurrent fetal demise. With that dysregulation of placental vasculature, as you have less conversion, less penetration, you end up with more and more endothelial reticulum stress, you end up with oxidative stress, pro-inflammatory cytokines, all sorts of changes and potential targets for intervention. And in fact, it's the dysregulation of the spiral arteries that is thought may be leading to the preeclamptic and hypertensive disorders. On the top, you see a non-gravid uterus or normal pregnancy with exuberant connections, a lot of blood flow, very healthy villi, and at the very bottom, as you can see on your right side, severe preeclampsia with attenuation of those vessels, atrophy, well characterized, increasingly explored deeply in the realm of recurrent pregnancy loss. And in the realm of pregnancy loss and preeclampsia, the genomic era has hit. There are polymorphisms which characterize women at risk in various arenas, including vasoactivity, including oxidative states, stress and lipid peroxidation, immunogenetics, and endothelial function, which leads to review articles that talk about the multiple potential targets for preventing complications of pregnancy, which start with tender loving care, I think, interestingly, in every review article, but launch into more accepted and standardly applied things like anticoagulation, aspirin therapy, hormonal therapies when imbalances are discovered, immune regulation, looking at various interventions at various sophisticated levels of the inflammatory response to this process. And I'll point out, as a thrombosis person, that heparin actually for early miscarriage probably doesn't impact thrombosis, but rather its anti-complement activity, which is demonstrated in models of antiphospholipid antibody syndrome. So yet another cascade or system that comes into play in recurrent pregnancy loss. And with opportunities to prevent. And even preeclampsia. There's a standard out there, whether currently strongly endorsed or not from ACOG, that says let's give aspirin. If a woman has had a preeclamptic episode, to give aspirin based on this Cochrane review is perhaps not particularly harmful and may be beneficial to reduce the risks of complications. So what if I told you instead this lady has hemoglobin SC disease, or even sickle cell anemia? They are told their cradle will be empty because they have a genetic disease no one can fix, and they say call hematology. So they will come into our clinic seeking the answer for an underlying genetic disease, often completely unevaluated for any other cause of recurrent pregnancy loss. And to be fair, there is a notion out there that sickle cell disease is associated with pregnancy complications. When I had opportunity to review the data, and this is just for your reference at some future point, there are lots of retrospective case series, usually from single institutions. There's a cohort study from Jamaica. There's a randomized control trial from nearly 30 years ago. And then there are recent samplings of administrative data sets that are plagued, to be fair, by the vagaries of characterizing sickle cell disease and pregnancy complications. But let's go back to if that lady has SC disease, which is the case I dealt with 3 months ago. There is no difference in women who have SC disease with women who have AA or normal hemoglobin in their maternal and their fetal outcomes. And yet that young woman had suffered through 2 losses without any form of intervention or evaluation on the premise that it must be the sickle cell disease. But in sickle cell anemia, it's true, there are some fairly consistent findings. Babies tend to be small for gestational age or have low birth weight, although the recent data out of Jamaica suggests that if you look at the mom, babies aren't all that much smaller until perhaps very late in the 3rd trimester if there's evidence of placental insufficiency. There's probably more preterm labor. There's a potential increase in sickle cell disease activity I think we all recognize, although it is not universal. And then inconsistently, there's increased risks, perhaps, of miscarriage and fetal demise and hypertensive diseases. So just to show you an aggregate set of data for background information, in sickle cell anemia, it's true that the babies tend to weigh about a pound less on average. And there's a larger percentage of those women who give birth to babies that are less than 2.5 kilos. In terms of obstetrical complications, these are the things that showed up in that Medicaid data study from recent years. And I'll point out that they compared not just normal women who apparently normal with sickle cell disease, but women who had other conditions, diabetes, end-stage renal disease, lupus. And it turns out that sickle cell disease does fare more poorly in terms of preeclampsia, totally confounded in terms of its coding, but at least as a recognized hypertensive complication and an earlier C-section, but not nearly as bad as women who had other forms of conditions, which, by the way, would get a review, would get aspirin, and would get anticoagulation. What do we know about the placenta and sickle cell disease? Surprisingly little. There's a few case series that looked at the histopathology in sickle cell anemia. As you would expect with a disease that may compromise vascular flow, there's multifocal fibrin deposits, fibrinoid necrosis, sclerosis, signs of placenta in distress with increased syncytial knots, compensatory proliferation of trophoblasts. Interestingly, while these changes are universal, the effect on the baby is not. And in fact, one of the authors proposed that this is a great paradigm to understand what the effects are of a change in vascular flow and hypoxia on the placenta in general, independent of sickle cell disease. More recently, people have begun to look at more vascular markers, as you can see characterized, and there's even a recognition that sickle red blood cells adhere to the extracellular matrix of trophoblasts. So this appears to be a targeted organ, much as other organs are in sickle cell disease. Does this mean it's a weaker organ? Actually, it turns out placental abruption and premature rupture of membranes, even the tone of the uterus is not significantly different in these women. But they are often sent to us, and if you go to Midas, you're going to get a muffler. Hematologists fix anemia. And this is despite, we do this, I won't say over and over again because this is truly understudied, but we keep trying to fix the anemia, even though there has never, in all of these conflicting outcome studies, never been a correlation between anemia and maternal and fetal outcomes. But we tried. Mabel Koshi tried in a hard way doing randomized controlled trials. a trial of transfusion versus control without any impact on maternal or fetal outcomes. The French said we can do it, we can do it better, we're going to start transfusion as soon as conception is recognized in 128 women, and the outcomes were the same, although they, as compared to controls, and as compared to SC disease, where there was no difference, let me say again, between people with SC disease and hemoglobin AA. It is true that Dr. Koshy demonstrated we could impact the course of the sickle cell disease in women with transfusion therapy, but other outcomes, including that which we seek, which is to save the pregnancy, to preserve the fetal growth, and to sustain the mom in terms of complications, has not been impacted. And this is just another slide to demonstrate a lack of difference and inconsistency even around controlling pain events in numbers that are far too small to draw a conclusion, which itself says something about the state of the science. So the placenta is a target organ in sickle cell disease. Transfusion and fixing red cells doesn't appear to change the outcomes. And as is true with all other women who have some other insult to the placenta, multimodal therapy is likely needed. And it seems to me the step forward here is not going to be necessarily modifying the red cells per se, but to look at the other interventions that block those downstream consequences. And just a word about that. This is a great experimental opportunity. Where else in any human with sickle cell disease after the first 6 years of life do we grow a brand new organ that has the potential to be unaffected if we hit the right intervention? It's an extraordinary experimental opportunity, and one that, when successful, leads to increased quality of life and significant happiness for the people living with sickle cell disease. The final case I want to bring about to make a couple of points. So this is a 35-year-old man with sickle cell anemia and chronic transfusion. Takes 120 milligrams of methadone a day for a history of multiple admissions for crises. And since we did this regimen for him, he had not been in the hospital for literally 10 years. And he was recently admitted with a dental abscess with exacerbation of his pain. Now, as Dr. Kutler had already alluded to, in the adult world, pain, and chronic pain in particular, is a ubiquitous phenomenon. And these are the specific data from Pisces that notes that despite what some of you in the room might be concerned about, that people are constantly coming to our doorstep every time they have a little bit of pain. In fact, they do avoid us until the last possible moment. That even days, they only spend a third of the days that they call crisis coming to visit us. And that there's an entire portion of this iceberg we'll never see because they experience pain that they wouldn't characterize as sickle cell crisis. So chronic pain is a reality. But you'd say to me, and I know it because the residents do it all the time, but he's on transfusion. You fix that disease, so he must be an addict. Why does he need 120 milligrams of methadone when you have fixed his disease with red cell transfusion? And so, as we all know, there's potential for structural injury that continues pain. There may be some ongoing vaso-occlusion. Transfusion only lessens the proportion to, at best, on a good day, 5 or 10% sickling red blood cells. And there may be sources of pain unrelated to sickle cell disease. And of course, the claim is he's addicted. And the only thing I'd point out on this slide, which, as you can imagine, makes me a big popular person on the ward, is that healthcare providers are 3 times more likely to be addicted to pain medication than sickle cell patients or the general population. And the problem really is, in this paradigm to think about, is that when human beings are exposed to pain, up to 5% of us with a single exposure will never not hurt again. So persistent post-op pain. 11% of people who have a laparoscopic cholecystectomy on an elective basis and 10 to 15% of women who have C-section will have persistent chronic pain. A single severe exposure. Predictors include young age, sickle cell, intensity of acute pain, sickle cell, degree of relief. The presence of pre-op pain certainly doesn't help, and QST testing, if you will, as Dr. Kutlar discussed, may help to predict some of the variants, and the role of genetics is underway. But what more cruel twist of nature could take place in the experiment of sickle cell disease, where in infancy, a single episode of acute severe pain could be heft-foot syndrome? And it turns out that children are quite resilient. Dr. Dampier in the audience has characterized how the transition from acute to chronic pain actually doesn't appear to take place until children enter adolescence and into chronic adulthood. But if all it takes is a lap chole for some of us, imagine what we should expect for chronic pain in the young adult who's had multiple similar exposures, and arguably perhaps with that inadequate pain relief, and then give them a menstrual period on top of everything else, so yet another source of pain. And so chronic pain, quite simplistically, may have to do with either you experience pain here, but you feel it in your brain, and then the amplification of the signaling through the dorsal horn and up the spinal cord can take place such that in the future, an innocuous stimulus like a touch, or a not so bad stimulus like a menstrual clamp, suddenly becomes a nuclear explosion in the pain centers of the brain. And if you fail to inhibit that downstream, in the reverse order, that can become cyclic and amplified. And so now, despite your hydroxyurea therapy, despite your transfusion that makes you only 10% of sickle form, suddenly the little vaso-occlusion that takes place is enough to in fact be the same as someone who hasn't had transfusion or be on hydroxyurea. And this is complex. I'm going to the American Pain Society. Who knew? I didn't get this in blood school. So it's complex. This is a simplified algorithm. I have no business as a hematologist trying to figure out how to spell Cymbalta. I've seen it on TV, but I don't know how to use it. And yet, pain experts would say, well, I don't know what you do after Cymbalta. I'm like, Cymbalta? I've never used Cymbalta in sickle cell. How many of your sickle cell patients are on Cymbalta? There is an entire science, a huge field people build entire careers based on the management of chronic pain. And yet, they leave it in the hands of the hematologist. Well, let's go back to the case, because there's another point I want to make in closing. So this young man developed chest pain, a rising troponin. In fact, he burst troponin, and then had VTAC. And who did they call first? Hematology at 6 in the morning. Because the ICU intern said he needs an emergency exchange transfusion because he had intracoronary sickling and was having a heart attack. The ICU fellow says, you are not very sophisticated. This is microvascular sickling with focal areas of infarct. And the hematologist who got the call said, crap, it's the methadone. With the Q1T phenomenon, I knew that was a lot of methadone, even though he'd been fine for 15 years. And here's how it rolled out with the multidisciplinary team. So this hematologist said, look, he's been exchanged, his percentage S is 10%, and intracoronary sickling and even intramuscular sickling within the myocardium is not really recognized. And if it does, it's really quite rare. The pain service said, I'm sorry, VTAC doesn't occur with methadone. I looked that up. It's actually not as common as you would think. But we were saved, arguably, by the non-invasive cardiologist who said, well, that ain't VTAC from Q1T. It's the wrong, it's got the wrong shape. The echo didn't show focal ischemia, which we knew, even though the left heart cath guy rolled in and proved he had clean coronaries. And what the non-invasive cardiologist says is this is classic for myocarditis. This polymorphic VTAC that's multifocal, this massive relief of troponins without a focal deficit. He would have had to lost half his ventricle for that troponin of 14. And he said, you know, that's reported with Hep C, which it turns out the patient has. But it got me thinking, and now a collaboration with this non-invasive cardiologist, is that sudden death, which of course VTAC will give you if you're not in the hospital, is a recognized cause of death, especially in adults. And there is an evolving line of research, don't let me forget to mention that Tom Coates and others have looked at an autonomic dysfunction that may lead to an arrhythmia. But it got me thinking about all these pathobiologic processes that we've heard about and we'll hear about more later that include oxidation and inflammation. And so without vascular occlusion, maybe the myocardium in some people does become a target, not from occlusion, not even from adhesion or infiltration, but actually some sort of activation that leads to a myocarditis that could contribute to sudden death. Now, do I know that to be true? No. Should we have given him steroids? He said no, the invasive cardiologist, because it looks like it has resolved. But it's a great example of thinking well outside the box. And so clinical sickle cell disease is a coat of many colors. There's multiple mechanisms, there's multiple approaches, and we need multiple participants at the table. When I Googled a coat of many colors, I actually heard about a Dolly Parton song. Go figure. And it turned out this was where, in the song, as only country western could be, it was about a poor family, where the mom sewed together the pieces she could pull together into a coat of many colors. And even the poorest of folks, even those of us who struggle the most for funds, together, I think collectively, we can create this coat of many colors and advance the field. Now, this is an eye test because it's blurry. So, Jim, do you know what this is? Do you recognize this? It's a test.
banana split?
No, 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 no. So this is a Lollapalooza. Lollapalooza is a Bridgman's ice cream special. And my only point is there's a lot of good stuff inside of Lollapalooza. There's 8 scoops of ice cream, there's 4 or 5 different toppings, there's real whipped cream, and 3 cherries on top. Not 2, but 3. It won't surprise Dr. Ekman when he knows me. I actually have eaten an entire Lollapalooza myself. It's a little challenge at Bridgman's. But it goes a lot better where there's lots of good stuff inside sickle cell. There's a lot of good stuff inside of Lollapalooza. And we need to bring many people to the table. And I've always been encouraged by the enthusiasm in the eyes of residents and otherwise cynical colleagues who say, wow, I had no idea sickle cell disease was so interesting. I had no idea that there's so many different ways to think about this and that we can work together for this. And so I'm hoping we can all, I trust there's Lollapaloozas on the luncheon menu? Perhaps not. Thank you very much.